Hello and good afternoon, all of you. I Yep. So I hope all of you are doing good. You're safe wherever you are right now, back at your home. And as I'm seeing some of you messaging me over the last 24 hours, I see you're also getting a lot busier with your colleges opening up your online lectures and also other PG postgraduate entrance classes that you have joined also opening up the lectures. So as I said in one of the groups, I think right now you guys seem to be the busiest of the lot. So I hope you are enjoying this period. Stay safe, stay at your home. And I'm right now talking for my clinic, and I am glad to connect to you on this platform. Yesterday, we started talking about hypertension. So what I'm going to do today is we are going to talk about hypertension in a little more detail today. So the idea is going to be how do we approach these patients when they come to us with hypertension. We are going to kind of divide our talk today in two parts. First, we are going to talk about what are the known risk factors or pathophysiologic factors in hypertension. And second, we are going to talk about how do you treat these patients. And when I talk about treatment, there is a big area of controversy there, which is where I would like to spend some time, right? Let's start with the lecture straight away. And let's start with what are the pathophysiologic mechanisms in hypertension. Please make a note of this. What are the pathophysiologic mechanisms in hypertension? Okay. So first and the foremost, mechanisms of hypertension, if you think of it, yeah. So we are talking about systemic hypertension over here. And if I think of what are the mechanisms of hypertension, the first and the most important, which is important as far as the mechanism goes and also as far as the therapy goes, is sodium homeostasis. So please make a note of this. One of the most important regulators of blood pressure in the body is sodium itself, and increase in dietary sodium. Increase in dietary sodium is right now considered one of the highest risk factor for patients developing hypertension. And one would always consider ki why would there be high sodium in the diet. Now it's a very absolute rule that you try telling anyone that lower the sodium in your diet, and almost everyone is going to say that I eat low salt diet. So if everybody believes that they are eating low salt diet, where is the salt coming from? Please make a note of this. A lot of salt comes from hidden sources. So it isn't really that the patient is putting salt, extra salt in their diet, but processed foods. Please make a note of this. One of the very important source of the sodium are processed foods. So anything which has preservatives, anything which has been a bakery item, biscuits, all these things, all those yummy looking things and yummy things that we eat, a lot of them have preservatives which has sodium, right? So please remember a big source. It is estimated that in the Western country, 75% of sodium intake throughout the day is coming from processed foods. So please mark this as important. Sodium is considered one of the high risk factor, and around 75% of sodium, at least in the Western countries. Even in India, in the urban population, this could be a high number, but this sodium is very importantly responsible for hypertension. Now, one of the things that happens is whenever we have an increase in sodium, there are going to be compensatory mechanisms that come into place. And that compensatory mechanism basically is increase in production of nitric oxide. And this increase in production of nitric oxide is associated with the decrease in peripheral vascular resistance. In other words, it is associated with vasodilation. Right. Now, this is a normal compensatory response that as anyone has a high sodium in his diet, that would cause release of nitric oxide, that would cause vasodilation. The problem happens when this compensatory response is inadequate. Please make a note of this. Patients develop hypertension when the compensatory response does not match up with their sodium intake. When the compensatory response is not up to the mark, that increased sodium is associated with hypertension. And these patients where the compensatory response fails, we say that they have developed what is known as salt sensitivity. Please make a note of this word, that patients in whom the compensatory response has failed, we say that they have developed salt sensitivity. There's also a definition to the salt sensitivity. You can write this down. It's not necessary that you remember it. Salt sensitivity means anybody who has a sudden intake of 4 to 5 gram of salt will experience the systolic blood pressure rising up by 10 millimeter of mercury in the next few hours. So what is salt sensitivity? You can actually check for this. We don't do it in routine practice, but I want you to remember the idea that patients in whom the compensatory response is not working, they develop what is known as salt sensitivity. That means on consumption of salt, a high amount of salt, within next few hours, the systolic blood pressure shoots up. Sodium is responsible for water retention. So it is responsible for increase in water reabsorption from the renal tubules, and that also is contributing to hypertension. Right? So sodium contributes by two ways. One is the way a compensatory response fails. Second is causing retention of water. There are other things that sodium can also do. Some things which are yet to be explained as to how does it really do that. But please make a note of this. There are other mechanisms by which sodium can cause hypertension. It at least favors endothelial dysfunction. It might not be causing it directly, but high sodium diet has been associated with endothelium dysfunction. We're going to see the role of endothelium again in some time. And it is also associated over long term with production of TGF beta. We had seen TGF beta as causing renal sclerosis yesterday, the glomerular sclerosis. Here, a systemic increase in TGF beta is going to cause vascular sclerosis. The systemic blood vessels will undergo sclerosis or fibrosis, and that means overall, with age, if someone continues to be on high sodium diet, patient will develop hypertension. Some things are very easy to understand that sodium is going to cause water retention. Some things are what we are understanding from trials. So I might not be able to explain how sodium really causes endothelial dysfunction, but we are seeing that these patients tend to have other markers suggestive of endothelial dysfunction. One big step is sodium. We are going to see that in our treatment that matters. The second big mechanism is again something that matters in our therapy, is renin angiotensin aldosterone system, hyperactivity of it. Please mark this as important. Patients who are hypertensive, in most of them, there is an hyperactivity of renin angiotensin aldosterone system. There's a hyperactivity of the RAS system. Now, we know this story that renin is responsible for giving us the end product, that is angiotensin 2. And angiotensin 2 is, amongst many other actions, is responsible for giving us the production of aldosterone. Right? So I'm not going into the complete cycle. I'm just telling you that we know this, that renin is responsible for angiotensinogen to angiotensin 1. Then angiotensin 1 will cause it to become angiotensin 2. Angiotensin 2 will act on the efferent arteriole, we know that part, but it is also going to act and increase aldosterone. Right? Now, out of these, please make a note of this, angiotensin 2 is thought to be a big culprit in hypertension. We have mentioned angiotensin 2 even when we were describing CKD, if you remember, that angiotensin 2 has a lot of local inflammatory action that it does, which increases or progresses CKD. We have mentioned that in CKD. That same angiotensin 2 is responsible for worsening of hypertension as well. So please make a note of this. Angiotensin 2 is responsible for worsening of hypertension. It's considered one of the prime molecule responsible for hypertension, and it does it via various mechanisms. One, it increases sodium reabsorption. It increases sodium reabsorption. It directly increases sodium reabsorption from the proximal convoluted tubule. This is its direct action. It directly increases sodium reabsorption from the proximal convoluted tubule. It also indirectly increases sodium reabsorption by acting on aldosterone. Remember, we are going to speak of aldosterone now. Aldosterone also causes sodium reabsorption, and angiotensin 2 indirectly by activating aldosterone is responsible for sodium reabsorption from the collecting duct. So aldosterone causes sodium reabsorption from the collecting duct. Therefore, angiotensin 2 has a kind of indirect action to cause increase in, this I'll write as indirect action to cause increase in sodium absorption. So one of the things that angiotensin 2 does is that it causes increase in sodium absorption. But there are other things that angiotensin 2 does. The second thing, it again, even angiotensin 2 has been associated with endothelial dysfunction. Even angiotensin 2 has been associated with endothelial dysfunction. Third is it is also associated with immune mediated changes. It is also associated with immune mediated changes in hypertension. We are going to see some of the immune mediated changes in some time, and in that it has what is known as a pro-inflammatory action. So angiotensin 2, its primary mechanism is increased sodium reabsorption. Its other mechanisms are endothelial dysfunction and a pro-inflammatory action, very similar to what sodium itself was doing, right? So one way that it is going to act is directly angiotensin 2. The second way is by acting on aldosterone. I would like to add over here, please make a note of this, that aldosterone causes increase in sodium, and aldosterone therefore also causes volume overload. Please make a note of this. Aldosterone is also responsible for volume overload. Remember, renin-angiotensin-aldosterone system is one of the main mechanisms by which hypertension can be explained. Now, there is one enzyme which we said was responsible for conversion of renin was going to cause conversion of angiotensinogen to angiotensin 1, and from angiotensin 1 to angiotensin 2 there was an enzyme, angiotensin converting enzyme. Now there is another enzyme which is responsible for breaking down of angiotensin 2, that is also called angiotensin converting enzyme type 2. Pay attention to what I'm saying. The usual ACE that we know and the usual ACE inhibitors that we know act on this angiotensin converting enzyme that converts angiotensin 1 to angiotensin 2. But there is another angiotensin converting enzyme called angiotensin converting enzyme 2. And this ACE2 is responsible for metabolism of angiotensin 2. And now we are realizing, please make a note of this, within the RAS system, this is the protective enzyme. Please make a note of this, that within the RAS system, angiotensin converting enzyme type 2 has been shown to have a protective or beneficial effect in hypertension. It has been shown to have a protective and beneficial effect in hypertension, mainly because it metabolizes angiotensin 2. Mainly because it metabolizes angiotensin 2. It has also shown to have an independent vasodilatory effect on the blood vessels, and it has also shown to have an effect of natriuresis. Natriuresis means losing sodium in urine. So if someone is to ask you, does ACE have any action in protection against hypertension? Then they are not talking about this ACE, which is where your ACE inhibitors work. They are talking about ACE2. Please mark this as important. ACE2 is an enzyme which has a protective effect in hypertension. We are looking at mechanisms of hypertension. The first mechanism of hypertension is increase in sodium. Second very important mechanism of hypertension is hyperactivity of the RAS system. There's only one protective part of that, that's ACE2. The other mechanisms important but not as well understood. Third mechanism is by the natriuretic peptides. The third mechanism is by the action of natriuretic peptides. We have two very important natriuretic peptide, the atrial natriuretic peptide and the brain-like natriuretic peptide, ANP and BNP. Two natriuretic peptides that you have, atrial natriuretic peptide and brain natriuretic peptide. As the name suggests, atrial natriuretic peptide, please make a note of this, is released by stretching of the atria. Whenever there is an increase in volume, that increase in volume will stretch the atria, that will cause release of ANP. And BNP is released by the stretch on ventricles, not in the brain, but in the ventricles. So please make a note of this. These two are released in response to volume overload, released from the atria and released from the ventricle. And as the name suggests, their primary action is loss of sodium in urine. So they cause natriuresis. The primary action is causing loss of sodium in the urine. This they do by doing three things. Please make a note of this. So what these atrial natriuretic peptide and brain natriuretic peptide do is they do three things. One, they tend to increase the GFR. They would tend to increase the GFR and thereby causing more urine to be formed, and that is the uresis part. Right? Second, they cause a decrease in the reabsorption from the proximal convoluted tubule, decrease sodium reabsorption from the proximal convoluted tubule. So if sodium is not getting reabsorbed from the PCT, sodium is getting lost in urine. And the third action is an indirect action, that is they inhibit the renin-angiotensin-aldosterone system. So that's an indirect action that they inhibit the previous one, and because of that these patients tend to have a decrease in blood pressure. So totally, whenever there is an action of ANP and BNP, the net result of action of ANP and BNP should be a decrease in blood pressure. The net result of action of ANP and BNP is going to be a decrease in blood pressure. That means hypertension would develop if a patient has a deficiency. Please make a note of this. Deficiency of natriuretic peptide is associated with hypertension. Deficiency of natriuretic peptide is associated with hypertension. So if someone is not able to make adequate amounts of ANP and BNP, that patient has a risk of hypertension. Not only is this patient at risk of hypertension, please make a note of this. These patients who have deficiency of natriuretic peptide, they are also shown to be at risk of developing heart failure. They are also shown to be at risk of developing insulin resistance. Now, this is something that is very difficult to explain, but we have seen that there is a strong association between lack of natriuretic peptide and insulin resistance, which means development of diabetes mellitus. So deficiency of natriuretic peptide seems to be a much bigger metabolic problem than just hypertension. It is associated with hypertension, associated with heart failure. It has also been shown to be associated with diabetes mellitus. And patients who are obese are the ones who have the highest risk of deficiency of natriuretic peptide. So one can say obesity, you already know that obesity is a risk factor for hypertension, obesity is a risk factor for heart failure and diabetes. So one can say that one of the indirect ways in which obesity contributes to all of this, of course, obesity has a direct contribution to insulin resistance also, but one of the indirect way is causing deficiency of natriuretic peptides, right? There are three other mechanisms I'm going to talk about, but I don't want to go overboard right now. I'm just going to hold and I'm going to keep this slide up for you to have a look. That sodium, that is increased dietary sodium, hyperactivity of the renin-angiotensin-aldosterone system, where angiotensin 2 has emerged as the biggest culprit as of now, what we understand, and a natriuretic peptide, a deficiency of that has been associated with hypertension. Right? So I'm going to see if there are any questions. Okay, for checking for the vasodilatory response of sodium, so sodium sensitivity, I have given you the systolic blood pressure. Shouldn't we also check for diastolic blood pressure? Well, yes, the diastolic blood pressure we expect will increase. Definitions are standardized based on certain things. So this is a recurring theme at Quest. You know, I always keep on saying this, and it's really tough for me to get this point across, but I'm going to try and keep on saying this again and again. Do not buy what was sold to you in first year and second year of MBBS. I'm saying this. Do not buy what was sold to you in first year and second year of MBBS. What was told to you, unfortunately, is that we understand science in a certain way. No better time than COVID to get you to understand that we don't understand science. We understand parts of a fractured science. It is not the cause that comes first. It is the effect that comes first. Cause we are searching. Look at COVID. We have seen the effects. We are actually not even seen all the effects. We have seen some of the effects and we are searching for its causes. Similarly, When it comes to something even as basic as hypertension, you're going to see a controversy that I'm going to put in front of you now. We don't even understand hypertension in its complete details. So to answer your question, wouldn't diastolic blood pressure increase? Well, logically, what do you think? Isn't it going to increase? It's going to increase. Why didn't I include it in definition? That's how I study it. When we study certain things, we define parameters first so that you and me are talking of the same language. If I say salt sensitivity and you say salt sensitivity, it should mean the same things. So we took one parameter and defined it. Why did I not take diastolic with it? Well, think logically, why did I not take diastolic with it? Most likely because it wasn't varying in the same proportion. That means a patient whose systolic blood pressure was varying every time by 10 wasn't necessarily showing that the diastolic was varying by the same 5 or 2 or 3 or whatever, right? So we define parameters that way. I am not against anybody asking questions. Of course, please ask questions. Don't misunderstand that I kind of, saying no to your questions. In fact, I'm glad you're asking questions. But I would want you to think, and I would want you to change the way you think. Do not go in that way. See, there is a fracture, big fracture, a big no, deficiency in the kind of education we offer you. And in that, we teach you as if we know everything, and just you're supposed to take all the physiology and just match it up with pathology, and there you have that's medicine. If it was that simple, why are we not able to solve something like a respiratory pathogen? We are not able to because science doesn't go ahead that way. We will look at the effects first. Then we will try to decipher what might be the reason. Then we try to define certain parameters. Then we go and try to treat it, right? So again, I come back. Your question is very simple, but what I'm trying to address is not the question, but the reason of that question. The reason of that question, as I see it, is your belief that there is a cause and that is going to lead to an effect. There is an effect, and we are going to search the causes. So look at the effects. Yesterday also I saw some questions which are on the same track, right? So pay attention to the effects. Medicine is not same as pathology, right? Pathology has a lot more things that I know already. Medicine has a big unknown. I'll have to define, hold on to certain things, and then take my steps ahead, right? I hope it does make sense to what I just now said. Okay. How does deficiency of natriuretic peptide cause heart failure? To keep it simple, it doesn't necessarily cause heart failure. It is contributing to heart failure. And remember, natriuretic peptide is supposed to act in response to volume overload. Whenever there is volume overload, natriuretic peptide should cause diuresis or natriuresis. That should correct the volume overload. If there isn't natriuretic peptide, it will allow the volume overload, which will allow the heart failure to worsen. So it doesn't cause heart failure, it worsens heart failure as we think of it. How do natriuretic peptides inhibit RAS? I don't think we know the answer to that question. At least I don't know the answer to that question. How does natriuretic peptide inhibit RAS? I do not know the answer to that question. BNP is produced by the stretch of the ventricle. I'm answering the question. What causes hyperactivity of the RAS primarily? Again, not sure. In fact, what causes hyperactivity of the RAS in itself is a big puzzle. And also, some of you at least must be knowing this, that the RAS that I'm talking of right now, there are two RAS systems. One is the kidney wala RAS that we have heard over the last few days. But there is also a RAS system which works locally in tissues. So within liver, within lungs, there are going to be local systems of RAS. And how are they really controlled is beyond our science today. We really don't know what keeps them active, what keeps this RAS system hyperactive. This is a question you are going to ask me again when I come to, you have asked me this question already, by the way. I mean, not you as in the person who has typed the message, but some of you have thought of this question already when I spoke about CKD. Why was the RAS system active? I don't have an answer. Hypertension, why is the RAS system active? I don't have an answer. When you come to heart failure, you realize over there also, the RAS system continues to be active when I don't want it to be active. Reason? I don't know. I just know that it seems to be working more than what it should be doing. We don't know why is it doing so, right? Is deficiency of natriuretic peptide associated with previous MI? I am not sure of something like this. I don't think I have read anything of this sort, so I can't comment. I do not know whether it is associated with previous MI. Do ACE inhibitors inhibit ACE2? No, ACE inhibitors inhibit the first ACE. How does obesity cause deficiency of natriuretic peptide? We do not know. At least to my understanding, I do not know. Does the vasoconstriction effect of angiotensin II not significantly contribute to hypertension? It does. So thank you for reminding me of that. Please make a note of this, that angiotensin II also has a vasoconstricting effect. It's not its primary reason for hypertension, but it does have that effect. Please make a note of this. Angiotensin II also has a vasoconstrictor effect, but that's not considered as its main mechanism of action for hypertension, but yet it does have a vasoconstrictive effect. Where does ACE2 come from? I'm not sure again. I'm not sure where does ACE2 come from. Are there any drugs? Not yet. We do not have drugs which act on ACE2 yet. Which has a greater contribution to reducing blood pressure, ANP or BNP? I have never read any comparison between the two. I don't think that I know the answer, but my understanding of physiology goes to saying it should be ANP, but I have not read anywhere that ANP contributes more than BNP. But my own take on it is it should be ANP which contributes more to lowering of blood pressure than BNP does, but I have not read this somewhere. I have answered this, and I'm saying this third time now. ACE inhibitors do not act on ACE1 and 2, they act on the first one only. They inhibit the first ACE. Okay, so I'll answer some of your questions, perhaps one-on-one. They are a little repetitive here, so I'll answer your questions one-on-one, right? And again, I would want you to hold down and realize we do not know everything about hypertension. I know a lot of you will have questions, aisa kyun hota hai, waisa kyun hota hai. My answer to most of your questions at this point is going to be, we don't know. Of course, there are some answers I might know, which I'll answer, but most of the questions that I'm getting right now, my answer is, I don't know. Why is obesity going to cause this? We don't know. These are associations. The cause effects are yet to be understood. We don't understand something as basic as hypertension, is the message I'm trying to give you, right? Okay, so I will take your questions. Please post them up and I will answer your questions as we go ahead. Okay, now let's go one step further. We are talking about what are the mechanisms of hypertension. We have said sodium retention is one, action of the renin angiotensin aldosterone system is one, action of the natriuretic peptide and a deficiency of them is another one. Next one is the sympathetic system, an overdrive of the sympathetic system. Please make a note of this. What are the other systems? I'll just enumerate them. So please make a note of this. What are the other systems which should be contributing to systemic hypertension? One is an overdrive of the sympathetic system and overactivity of the sympathetic system. Now, this overactivity of the sympathetic system has been seen specifically in certain populations. So which are the patients who are at risk of developing sympathetic system overdrive? One, it is more common in men than in women. Sympathetic system overdrive is seen more commonly in men than in women. It is also seen more likely in patients who are obese, patients who have high salt diet, and also patients who are having other risk factors like CK. Right. So sympathetic system overdrive, one mechanism that we understand, seen more likely in men, more in obese, more in patients with CK. Another mechanism is endothelial dysfunction, which I have been referring to in the previous two ones, that there is going to be endothelial dysfunction. Now, when we say endothelial dysfunction, please make a note of this, that normally the endothelium is responsible for making both vasodilators as well as vasoconstrictors. Normally, endothelium is responsible for making both vasodilators as well as vasoconstrictors. And the primary vasodilator is nitric oxide. The primary vasodilator is nitric oxide. Nitric oxide, which works by increasing cyclic GMP. Primary vasodilator is nitric oxide. The other vasodilator can be prostacyclin, that is PGI2. PGI2. The primary vasoconstrictor, as most of you must be knowing, is endothelin. Endothelin 1. The primary vasoconstrictor is endothelin. It could be the other prostaglandin, like thromboxane A2. Thromboxane A2, which are other vasoconstrictors, they can also contribute towards causing vasoconstriction, right? And one more important vasoconstrictor is our angiotensin 2, a locally made angiotensin 2, not the renal one, but local production of angiotensin 2. It can be produced by the local endothelium also in different blood vessels, and that can also contribute to vasoconstriction. So where you had mentioned that vasoconstriction can it cause hypertension, it comes under this mechanism of endothelial dysfunction and a locally produced angiotensin 2, where it's one of the mechanism, not the primary mechanism. Right? Now, a dysfunction of the endothelium means that there is a loss of this balance. Please make a note of this. Endothelial dysfunction means that there is, for some reason, an overproduction of constrictors, over and above vasodilators. And one of the topmost risk factors shown for endothelial dysfunction is smoking. Please mark this as important. One of the topmost risk factors shown for endothelial dysfunction is smoking. We have already seen some other risk factors for endothelial dysfunction. We saw two important risk factors here. One was overactivity of the RAS system. Second is high salt diet. So you could add that over here. So endothelial dysfunction is contributed by smoking. It can also be contributed by other things like high salt diet, by an overactive renin angiotensin aldosterone system. But remember, endothelium or blood vessels are also going to respond to inflammation. Please mark this as important. Chronic inflammatory conditions, a big one. Chronic inflammatory conditions, so conditions like CKD, patients like SLE, patients having rheumatoid arthritis, all these chronic inflammatory conditions also show endothelial dysfunction. Big problem for these patients. You have a lot of you tomorrow when you take up medicine as your subject. If you become physicians tomorrow, a lot of your time is going to go in seeing patients who have chronic illnesses. And these patients with chronic inflammatory illnesses are at risk of hypertension. So please make a note of this. Chronic inflammatory states are also going to cause endothelial dysfunction. Chronic inflammatory states are also going to cause endothelial dysfunction. Classical example could be someone having rheumatoid arthritis. We see very frequently that these patients tend to have endothelial dysfunction, right? So I repeat, endothelial dysfunction is basically when the vasoconstrictor production is more than the vasodilator production, and the topmost risk factor, remember, is smoking. But there are other risk factors like chronic inflammatory conditions, high salt diet, and overactive RAS system. I'm going to complete the list by an item which might surprise some of you in this list. That one more reason that we now understand is going to be responsible for hypertension is immune system dysregulation. So please make a note of this. Immune dysregulation nowadays is also thought to contribute towards hypertension. Immune dysregulation is also thought to contribute to hypertension. And there are two mechanisms which are, or rather two hypotheses which are now placed forward as to why immune dysregulation should cause hypertension. One mechanism they believe is there is an increase in pro-inflammatory cytokines. There is an increase in the pro-inflammatory cytokines, which over a period of time cause vascular fibrosis. They over a period of time cause vascular fibrosis, leading to increased peripheral vascular resistance. So chronic inflammation will cause vascular fibrosis, leading to increased peripheral vascular resistance. But there is an interesting theory coming up now that immune dysregulation, when there is a dysregulation of the T cells, when there is a dysregulation of the T cells, these T cells might be sensitizing the tissue to action of angiotensin 2. So angiotensin 2 comes at many places over here. So please mark this as important. It is believed that dysregulated T cells might be sensitizing tissues to action of angiotensin 2. So even if the patient does not really have a very overactive RAS system, the angiotensin 2 that is there might be contributing to a much more effect than it should have earlier because of T cells which are stimulating or kind of sensitizing the tissues to do it. Again, do not ask me how this happens. Honestly, I don't know how this happens. To my understanding, this is data coming from trials that we are now figuring out that yes, these patients have some abnormal T cells. We have shown that these T cells have receptors for angiotensin 2, and perhaps that is how it is increasing the effects of angiotensin 2. Right? It's a very interesting emerging theory that immune dysregulation could be at the heart of hypertension, at least in some of these patients. Right? So I repeat, mechanism of hypertension would include sodium overload, RAS activation, natriuretic peptide being on deficiency. These are the three more important ones. There are other mechanisms: overactivity of the sympathetic system, endothelial dysfunction, and a newer one on this block is immune dysregulation. Right? Okay. Now that should bring us to this question. I'm not seeing the questions right now. Okay, well, one more thing. There's something I want to say a little general about, not about hypertension. Last, again, 24 hours, I have got at least 4 or 5 messages from all of you from different places, not from the same center, saying two things. One is this idea that we are giving out the WhatsApp, the link to you. Isn't it possible that someone else can see? So, well, till last week, the lectures were on YouTube available, and those lectures are still available on YouTube. Nephrology initial first, I think 7 lectures, they are still available on YouTube. And anybody who wants to see that, even if that person, that student is not a student of Quest Medical Academy, can still see those lectures. We had committed to that and we continue to do that. These lectures that you are seeing right now, we have shared the link only with you. Only those students who are registered part of Quest programs are on the WhatsApp groups, and we have shared them with you. Now, we are putting our trust in you. See, end of the day, all said and done, I am a physician and I'm a teacher. That's what I am. And what my company does here is teach. We will take a firm responsibility of doing what we do, and we'll do it in the best possible way that we can do. That I can commit to you. And we'll put our trust in you. So when we give out the link to you, I have absolutely no control over whom do you decide to give that link to. I'm not giving you ideas. I'm telling you I have no control over that. And I honestly, beyond the point, do not intend to control that either. I'm stating my intentions very clearly. I'm a teacher. I would continue to teach. That's my first commitment. None of us asked for COVID. Those of you who are in Bombay and Pune, your lectures, these lectures were supposed to happen in classroom. And they would happen in classroom once the classrooms open up. You're looking at the pictures outside. You know what's happening out there. Those of you who are not in these two cities, well, the lectures in your city were supposed to happen again in classroom. So this was never going to happen. This was never the plan. But now that it has occurred, we have to do the best with what we have. I can spend my team's energy and my energy in either of these two things, improving the quality of lectures and the content that we deliver to you, or bother about this ki aur kisko dikh raha hai. Honestly, beyond the point, I'm not bothered about aur kisko dikh raha hai. I have taken my due precautions of giving it to you. Now, if someone of you decides to share it with the rest of the world, be my guest. I really don't have anything to say there. We put our trust in you, and I trust that your judgments are correct. Let me also tell you something which is heartening and disheartening at the same time. When the free lecture started, well, on this side, I can see how many of you are viewing it. I don't know which one of you is viewing it, but I know how many are viewing it. I did see that the first 2 lectures saw a surge of close to 16,000 plus people watching the first 2 lectures. By the time it ended and I stopped those lectures, there were close to only 5,000 people actually seeing it. Such a huge drop. Even when it is free, only interested students are going to see it. I believe you have joined Quest because you're interested in learning. So let's focus on that part. Let's not be a little worked up with this idea कि किस और को दिख जाएगा. अरे कितना देखेगा देख के, you have like close to 200 hours of teaching or more that happens at Quest if you look at the whole course. But 200 hours, anybody, even if you give them free, they'll not see it, right? So don't bother about it. Bother about your learning and focus on that. That's my request. That's all I can do. I can request you, right? The second one is a more important suggestion, and I really accept that suggestion. We have thought that through. uh, this idea that why are we using YouTube if we have Zoom? Where you can see somewhere here there must be a big logo of Zoom, right? So why are we using YouTube when we have the access to Zoom webinars? I'll tell you the reason. The reason is 2017 onwards, I have been using Zoom. So a lot of you must be using Zoom perhaps for the first time. Some of you must have been aware of it. But Quest has been using Zoom since 2017. Sorry, 2018. 2018, my first batch went on online, and that time I was using Zoom, exactly this platform. And I have seen how Zoom works. There is a problem with Zoom that the bandwidth required on both sides is quite high. Even if I use a webinar, and if there are going to be all these number of students on the other side, the bandwidth requirements are going to be quite high, is my understanding of Zoom, which means I can still do the Zoom webinar. Your buffering period is going to keep on increasing. I've seen that when last time I was trying to run this for few centers, they were sitting in the classroom and watching it, but you can talk to your seniors and they'll tell you that there used to be buffering. You don't experience that buffering with YouTube as much as it will happen with Zoom. The servers of YouTube are much better than the servers that I think Zoom has at present, and Zoom is overworked at this point. Once the lockdowns open up and the bandwidth requirements because work from home might go down, there is a chance that we might be able to change it. I do not know how that will work out. When, as and when that is feasible, we'll try doing that, right? But as of now, I think we have thought this through. Even, of course, we are concerned about the privacy issues here. But I believe that it's rather than me trying to say कि दो लोग extra ना देख ले, I would say कि जो 500 लोग 600 लोग देख रहे हैं वो ढंग से देख ले. Two people seeing it extra is neither my loss nor your loss. Two people learned more. We are students of medicine, both you and I, right? But at the end of it, what matters to me is what I deliver to you should be of the best possible quality that I can deliver, right? If while delivering to you, it leaks out to two more people, I don't think that should bother you or me, right? Again, I'm not challenging your ideas about it. I'm saying let's focus on what we have at hand over here and let's make the best of the situation that COVID or this whole pandemic has thrown at us, right? So let's focus on that part. I take all your suggestions. Please send me your suggestions, but don't feel bad if I am not able to implement them. We have thought them through. There are limitations here, and I acknowledge them, right? But my primary delivery to you is the content that you are getting, and I can promise you nobody is interested in listening to this content beyond a certain point. Those who are interested have already joined the course, right? So let's go further. Now, we are talking about the mechanisms of hypertension. Now let's talk about how do you approach a case of hypertension. As in, what do you do when you have a patient of hypertension? The first thing you would like to do if you get a patient of hypertension is, of course, look at his blood pressure, but define hypertension. Please make a note of this. How do you define hypertension? How do you define hypertension? I'm sure all of you know the answer, and I'm equally sure that all of you are wrong, right? That what is the definition of hypertension depends on, well, it depends on where are you, which continent are you in, right? So I'm going to tell you a small story over here. Don't write this story, of course. Hypertension has been a very interesting journey in the last 1 decade. And this is where the controversies also start. So there is something called Joint National Commission, JNC, which was a body which was supposed to give us the definitions of hypertension. Now, JNC 7 happened, and then JNC 8 was going to happen. These were the additions which were coming. JNC 8 was supposed to give us the definition of hypertension, but it got a little late, delayed by a few years actually. And by the time JNC 8 came up, it had looked at the data science of that era. This was, I think, 2012 or 14. And it had said, okay, based on everything that we understand, it looks like 140 by 90, a blood pressure systolic above 140, diastolic above 90 should be called hypertension. And we should try that everybody's systolic, diastolic blood pressure should be below 140 by 90. They made it very simple. But the world started criticizing. Everybody said that if 140 by 90 is the target that you're keeping, before JNC 8, the targets for managing hypertension were actually strict. There were times, and some of you might remember that in management of CKD, I mentioned the blood pressure target. I had mentioned 130 by 80. And then someplace I mentioned 125 by 75. So these were the targets before JNC8 came. So people started saying, nahi yaar, JNC8 has relaxed it too much. The guideline came under severe criticism. 2015, there was a huge and a wonderful trial done known as the SPRINT trial. SPRINT, running. That's they were running. That was the short form abbreviation of it. So there was this thing called the SPRINT trial. You don't need to write this part, but understand how science goes further. So SPRINT trial tried to see that what happens if I compare patients in two groups. One group, I tried to keep the blood pressure below 140, and another group, I tried to keep the blood pressure below 120. So they called it kind of a normal control, which JNC8 at that time was saying you should be doing, versus intensive control below 120 by 80. And they found that if you follow these patients over a period of time, those patients who have an intensive control actually do better. That brings us to the question, why define hypertension? Well, yesterday I had said this, you define hypertension or any disease like this based on what is normal, but the normal has been increasing. Normal in the pre-industrial industrialization era, was 115 by 75. That has gradually jumped up. So you can't really use that, because now normally everybody would have a blood pressure higher than in the pre-industrialization era. So you might want to see, okay, at what level of blood pressure is there a risk of cardiovascular damage, renal damage, brain damage, so on and so forth. SPRINT did that. They said, okay, what is that risk? Are we able to bring down the risk? And they said, yes, if you control the blood pressure below 140, your target is don't cross 140. You are giving certain levels of doses. Otherwise, you try to control it below 120, intensive control. They found that intensive control patients are doing better than the routine control. That sent the whole world into a chaos, because one, JNC8 was difficult to digest, that you can relax, and then someone was coming and saying exactly diagonally opposite. A very well done trial was saying diagonally opposite to JNC8, and people have been divided since then as to what should be done. So what I'm going to offer you now are two different definitions. One is a definition that is followed by the European countries, and another is a definition which is followed by the American, or other US, America, which is where the SPRINT happened. So they continue to follow SPRINT, and the other ones, the Europeans, continue to follow similar to JNCA. So please make a note of this. What is the definition of hypertension? And this is a big slide, but please mark this part as very important part of our discussion today, that what is the definition of hypertension? Yeah. So I'm sure you are able to see this slide. There are two definitions. The first one, ACC-AHA, is the American side. ACC stands for American College of Cardiology. AHA is the American Heart Association. And ESC is the European School of Society of Cardiology, and ESH is European Society of Hypertension. And look at the differences. Please mark this as important, that there are two definitions for hypertension as they exist today. The American definition is blood pressure of more than 130 by 80 is hypertension, whereas the European definition is blood pressure of more than 140 by 90 is hypertension. We do not have consensus on what should be called hypertension, right? Not only are they different in what they say is hypertension, please write down the grading of hypertension. The grading of hypertension is grade 1 and 2 only for Americans, but grade 1, 2, and 3, that's over here, for the Europeans, right? I'm going to keep up the slide for some time. I would want you to write down this very clearly, that according to the American classification, grade 1 is 130 by 130 to 139, or 80 to 89 is grade 1. Anything more than 140 by 90 should be called as grade 2. So what is their definition of hypertension has already become grade 2 in the American school of thought. The European countries are allowing much higher blood pressures in that sense. They are allowing grade 1, grade 2, grade 3 to be in this way. There is a good chance that in your books you are reading this one. This is very similar to what JNC was. So you might have read the European ones in the books that you're reading. And this is how I define hypertension. But the last part of this is my target as to what do I want to achieve by therapy. Please mark this one as also important. For the American classification, irrespective of the age, there is only one target: keep it below 130 by 80. That is what I told you for diabetic nephropathy as well, that, or other CKD as well, that keep it below 130 by 80, right? Keep the blood pressure below 130 by 80, which means start treatment the moment it is more than 130 by 80 and keep it at all times below 130 by 80. Below 80. Please understand, it is not saying equal to 80, it's saying below 80, right? They are in fact saying that it is best that you keep below 120 by 75, right? So don't write this, or you might write this part, but if asked in an exam, the guideline has mentioned 130 by 80. So mention 130 by 80 as ACC-AHA classification. But the European guidelines are dividing the control based on age. Up to the age of 65 or below the age of 65, they are saying that the cutoff is same as the American cutoff. Even if they are saying that to start the therapy at more than 140 by 90, they are saying that once you start treating, bring down the blood pressure below 130 by 80. So remember that target and definition are different. But for anybody who is above the age of 65, the argument is that controlling the blood pressure too much might cause adverse effects. Patient might feel syncope, चक्कर आ सकता है, blood pressure बहुत कम कर लिया तो. इसलिए for people who are above 65, they are saying let the diastolic blood pressure be below 140. Sorry, systolic blood pressure be below 140. Diastolic, let it be the same, below 80. Right? Please mark this table as very, very, very important. Right? So there is this huge controversy as to what should be called as the normal blood pressure. And you might of course be tempted right now to say कि भाई ये सब तो ठीक है, then what are you going to follow in India? What is our classification of hypertension? Where do you call it hypertension? Honestly, there is no straightforward answer yet. We are waiting for the Indian guidelines to update on this one, but most people now have started taking the American route. We are anyways a system which follows much more American style right now. So please make a note of this. In India, by default, we now target 130 by 80, the American school of thought, right? Again, this is not yet official. It might be official soon once the guidelines in India come up stating what should be done. But till now, we are still with JNC. So JNC 140 by 80 कह रहा, 140 by 90 कह रहा था, but now we have shifted towards 130 by 80, at least in practice, right? This could be an area of questions and concerns. I am going to take your questions if there are any at this point, right? Okay, so a good question here. Should we decide a patient on routine checkup as hypertensive just by checking his BP once? Answer is of course no. So please make a note of this. This blood pressure, please make a note of this. The blood pressure that you check for the patient, there are 3 ways to check the blood pressure. Please make a note of this. The blood pressure that you check for a patient, there are 3 ways to check the blood pressure. The first is called office blood pressure. Well, even if we call it office is the term that comes from US, but it technically means a blood pressure checked in front of the doctor. So they call it the doctor's clinic or doctor's office bol rahe wo log. So they call it the office blood pressure. So please make a note of this. The first kind of blood pressure that you can check is the office blood pressure. The term is called office blood pressure, but what it means is a blood pressure seen in front of the doctor. That is the first type. If you are checking the blood pressure in office means in front of the doctor, then there are certain rules over here. Please make a note of this. For office blood pressure, that means in front of the doctor, the patient should have rested for at least 5 minutes before you check the blood pressure. The patient should have rested for at least 5 minutes before you check the blood pressure. The blood pressure should be checked in both the upper limbs plus 1 lower limb. The blood pressure should be checked in both the upper limbs plus 1 lower limb at least once. So of course, every time the patient comes back to you, can't keep on doing this, but at least once for a patient, preferably in his first visit, you should check the blood pressure in both the upper limbs and one lower limb. The ideal position is blood pressure should be checked in the sitting position. Ideal thing is that the blood pressure should be checked in the sitting position. And to define hypertension, you need more than or equal to 3 abnormal readings. So on one single reading, you cannot call it abnormal. You have to have at least more than or equal to 3 abnormal readings. You can decide this to have 3 abnormal readings either in the same setting. So now I'll tell you practically how these 3 settings work out. 3 abnormal readings work out. If I have a patient whose blood pressure right now is 180 by 110, well, I'm not going to send the patient home. I'm going to tell the patient, wait for 5 minutes, 10 minutes more. I'll check your blood pressure again. Maybe for some reason you're anxious and the blood pressure is too high. I would want to check it again. Or maybe I made a mistake. Maybe something went wrong. Right? I want to check it again. I would not leave that patient to go home. But if someone comes out like 130 is the cutoff I'm thinking of and the patient is at 139 by 80, I can tell him, okay, wait for 10 minutes more and I'll check again. You can, but we don't always do that because 139, I don't really think the risk is too high. I can always ask him to come back after 2 days or 3 days. Right? So these 3 abnormal readings could be in the same day or it could be on 3 different days also. It is your judgment, physician's judgment. So please make a note of this. 3 abnormal readings, which could be on the same day or on different days, depending on what is the setting. If you thought it was just a little bit of hypertension question mark, you could do it now, or you could ask the patient to come back, up to you. So the first kind of blood pressure that you see is the office blood pressure. The second kind of blood pressure that it can be used to call it hypertension is home-based blood pressure monitoring. Home-based blood pressure monitoring. This is the second way that you can look for blood pressure. Home-based blood pressure monitoring is used when you suspect what is called white coat hypertension. Please mark this as important. Home-based blood pressure monitoring is used to diagnose what is called white coat hypertension. Now, what is this white coat hypertension? Well, it is you and me who wears the white coat. So it is thought that there are at least some patients who are kind of anxious or afraid when they are in an unusual surrounding. Maybe when they are in front of the doctor, the fear of the doctor might be the reason that their blood pressure looks higher. That blood pressure which is high in front of the doctor but normal at house is called white coat hypertension. So please make a note of this, that white coat hypertension means that you find the blood pressure to be higher in the office of the doctor, but normal in home-based monitoring, right? So if you suspect that your patient could be having white coat hypertension, then you can do a home-based blood pressure monitoring. Of course, there is another use of doing a home-based monitoring. This can be used for routine follow-up, that in times like COVID, I would want my patient to measure the blood pressure at his home and maybe keep me updated that, okay, doctor, right now my blood pressure looks like this. What should I do and what should I not do? You could ask the patient for monitoring. This is a routine patient. In follow-up, you can ask the patient to monitor. Not for diagnosis. So diagnosis wise, HBPM is used only for diagnosing white coat hypertension, but it can be used in monitoring. Once I've diagnosed hypertension, when I've started therapy, I can use it for monitoring. One practical point here, when some of you might have seen the machines for home-based monitoring. Those are those electronic machines. Always, when you ask the patient to go for home-based monitoring, always calibrate it with your mercury sphygmomanometer, right? So please make a note of this. Before you start the home-based monitoring, at least once, ask the patient to get his machine and check it with your blood pressure machine. It should be that both of them are giving similar readings. It should not be that one is showing 140 and another showing 150 at the same time, right? Then there is some problem in that machine, right? So it should be calibrated with your machine. Take that precaution always, right? That's not written in the books, but that's a common thing that we do. We ask the patient to come for calibration of the machine when you're starting home-based monitoring. And the third one is what is called ambulatory blood pressure monitoring. Ambulatory blood pressure monitoring. Here, the patient is attached to a monitor for 24 hours. The patient is attached to a monitor for 24 hours and you send the patient home. Now, this is not a machine that the patient has brought. It is a machine that you have brought and rather you have attached to the patient. It's an automatic machine which keeps on measuring the blood pressure every 20 to 30 minutes. Please make a note of this. Ambulatory BP monitoring is when you have attached the patient to a blood pressure monitor. It's an automatic monitor. It keeps on measuring the blood pressure and recording, keeps on recording that in a computerized format. And it records the blood pressure every 20 to 30 minutes. Ambulatory blood pressure monitor. Why would I want to do something like this? Why would I want to check for ambulatory blood pressure monitoring? Now, make a note of this. Ambulatory blood pressure monitoring helps me when clinically I think this patient is at high risk of hypertension. Let me take an example. So let's think this through. Let's say I have a patient who has a history of something like obstructive sleep apnea. Now remember, I'm just taking an example, but remember yesterday I had told you obstructive sleep apnea is a cause of secondary hypertension. Now the patient is obese, the patient has obstructive sleep apnea. I feel the patient is hypertensive also. But every time that I have noticed his blood pressure, it looks normal. Now, it is possible that the patient came to me in the morning or evening at one time in his day, and that time the blood pressure was normal. It is possible that the blood pressure in the rest of his day is actually quite high, but somehow magically at the time he came to me, at just that time his blood pressure wasn't crossing the limits, and I thought he's normal. I could be missing such patients, right? So, doing an ambulatory monitoring helps me to pick up these patients who have hypertension but do not have that hypertension continuously. They have what are known as diurnal variations. So please make a note of this. Patients who have, where would I do ambulatory blood pressure monitoring? Patients who have high likelihood, high risk factors for hypertension, but do not show up with hypertension. You feel that the patient should be having hypertension, but you don't note that in your office or in your clinic or in your hospital. Then you do an ambulatory blood pressure monitoring. And a lot of these patients, please make a note of this. Once we have started doing ambulatory blood pressure monitoring, something new came to our understanding. This is almost a decade old technology now. Previously, we used to see only blood pressure in the clinics. But now when we see blood pressure ambulatory, we have realized that, make a note of this, a lot of these patients have nocturnal hypertension. When they are sleeping, that's the time when their blood pressures are actually high. Please make a note of this. A lot of patients tend to have nocturnal hypertension. If you were not doing their ambulatory BP, that means a 24-hour BP recording, you would have missed these patients of nocturnal hypertension. So there are three ways in which we look for hypertension. One is by looking at office, which is the commonest one, which is what you do. You can do a home-based one when you're suspecting white coat hypertension. You can do an ambulatory one when you can't record hypertension, but you think the patient is hypertensive, especially patients who have a high risk like OSA or otherwise, right? These are the three techniques in which you can measure blood pressure. Two more points I would like to add. Whenever you are seeing a patient of hypertension, please ask for relevant history of secondary causes. Please make a note of this. Whenever you are seeing a patient of hypertension, ask for relevant history of secondary causes. So yesterday we saw some renal causes, renovascular causes, OSA, CKD, and other causes. So ask for relevant history of that. Ask for risk factors for coronary artery disease and stroke. Please mark this as important. Ask history of risk factors for coronary artery disease and or stroke, like diabetes mellitus. So this is what you will need to ask for in history when you get a hypertensive case. Diabetes mellitus, smoking, dyslipidemia, diabetes mellitus, smoking, dyslipidemia, family history, of course, family history. Dietary history, what kind of diet does the patient have? Is it a high fat diet? Is it a high sodium diet? What kind of diet does the patient have? Physical activity, what kind of physical activity does the patient have? right, etc. So there are going to be many other small factors, but these are some of the prominent questions that you're going to ask when you get a patient of hypertension. So two things here I'm saying. One is that you need to look for evidence or history of secondary hypertension. Second, you need to look for history or evidence of associations, right? And on examination, please remember to do a detailed cardiovascular examination. All patients of hypertension do a detailed cardiovascular examination, which means auscultation, JVP, pedal edema, and all of that. So detailed cardiovascular examination. Okay, right? So we are talking about hypertension. It's a simple topic in certain sense that yes, we know what is blood pressure, we know how to measure the blood pressure, but it's a difficult topic in a global scale because it is a risk factor for many things, but we just don't know how to define it yet, because what is the cutoff at which you would like to define it, right? Let's move towards how do you manage a case of hypertension. Please write down management of hypertension. Please write down management of hypertension. So I'm going to complete the management story, and perhaps after that I'll take your questions. Hypertension is a straight linear discussion. There isn't much going around. So I'll finish up the discussion and then take your questions. I think that would be keeping it easy, right? So, yes. So treatment wise, we can divide it into two parts. We can divide management of hypertension into non-pharmacologic therapy and pharmacologic therapy. Let's start with the non-pharmacologic therapy first. So treatment wise, you can divide the management into two parts. First part is the non-pharmacologic therapy. Right? And by now you might have realized that the most important step in non-pharmacologic therapy is advise the patient to have a low salt diet. Please mark this as important. There is nothing which is more important than this advice. In all patients of hypertension, please stress upon having a low salt diet. And remember, you can't do that unless you've taken a good history of their diet. You have to ask them what are they eating, what kind of salt intake do they have, how much of bakery products, how much of biscuits, how much of preservative wale processed foods are they eating, what kind of lifestyle does the patient have. All these are really important questions. I'll give you an example. The other day, I was seeing this lady. She had come to me because of rheumatoid arthritis, and she had uncontrolled hypertension at that time. I mean, she was already on a drug, and the blood pressure was over the roof. So I told her that, let's start with some therapy. She was quite elderly; she was around 80. So I wasn't very keen on giving her very strong drugs. So I said, let me increase your drugs a little, but you'll have to focus on your diet. And then when I went into deeper into the diet, there was a very unique problem she had, that unfortunately she wasn't able to eat. So she said, I don't eat anything from outside except there's nothing that is cooked in my house. I am dependent on a tiffin for my food, and the tiffin comes from one particular source. So I was telling her you should have a low salt diet, but she said, well, I can't have a low salt diet because, well, I eat from a tiffin and otherwise I don't add any salt, but that tiffin is something I can't change. So these are very vital points in history. Once I know that, now I know, okay, I can't really rely only on low salt diet as a strategy for her. She perhaps would not be able to achieve that. That was her specific condition. Most people don't have that problem. But then taking a good history matters over here. So the first thing I'm going to advise is a low salt diet. How low salt? Again, different bodies are saying different things. Let's follow WHO here. It says less than 5 grams per day. So please make a note of this. Low salt diet, which according to WHO should be less than 5 grams per day. The American bodies have started recommending even lesser. So people are saying it should be even less than 3 grams per day. But well, we'll follow WHO. WHO says it should be less than 5 grams per day of salt intake, right? There is also one more thing that comes with low salt diet known as DASH diet. Please mark this as important. So in diet, you should be advising low salt diet, and that low salt diet should be combined with what is known as DASH diet. So please make a note of this: low salt diet combined with DASH diet. And this DASH actually was a trial. So please make a note of this. DASH is a mnemonic. It stands for dietary approaches in, or other dietary approaches to stop hypertension. This was the name of a trial which had tried different diets which can reduce hypertension. So dietary approaches to stop hypertension. This was a trial, and from that trial, they had tried different diets which were offered to patients, and they realized that a diet, so that is now called a DASH diet, which is high in fruits, vegetables, nuts, not the salted one, of course. So fruits, vegetable, nuts, low fat dairy products, low fat dairy products, right? A diet which is high in all of this, and of course, which is low in sodium, low in and cholesterol. So a DASH diet is a diet which is high in certain things and low in certain other parameters. And now it is said that patients should be advised what is called a DASH diet, right? If you try telling this to, maybe people of your parents or your grandparents' generation, I'm sure they're going to tell you, well, that's what we used to eat. I mean, still they would tell you that they eat this. The DASH diet brought back a big, kind of a controversy around the whole idea of junk food. The DASH diet showed, really speaking, that those populations, pay attention to what I'm saying, those populations which were having traditional food were having all of this in a good proportion. Those populations which were industrialized and having the urban junk food, as we call it junk today, it wasn't called junk by that time, but the processed food, the junk food as we call it today, they were the ones who are suffering from hypertension. Please mark this as important. Even if you are not in a position, see, tomorrow you could be dealing with a person who doesn't really understand what is DASH diet. I mean, you might be dealing with someone who comes from a state of the society where the education isn't really high. Convincing that patient that you need to have a DASH diet is really tough. Remember the golden rule here. Ask the patient to have traditional diet as much as possible. Let them have the stable food, stable foods, good fruit, good vegetable, good nuts is what is required to keep the blood pressure low, right? So please remember traditional diet versus the fat diet versus the, really speaking, junk food is really what DASH diet's hidden message could be said as, right? If you can, then remember everything and advice. But even if you remember this one rule, you have achieved good number of things for your patient, right? Remember traditional diet versus the non-traditional diets. Also part of DASH diet, but I'm going to keep it separate, is that we have realized that a diet low in sodium but high in potassium, please mark this as important, a diet high in potassium is also improving blood pressure. A diet high in potassium is also improving blood pressure. This also came from the DASH trial, and it is said that potassium of roughly 4.7 gram per day, potassium intake of roughly 4.7 gram per day, provided the patient has or rather does not have CKD. Of course, if the patient has CKD, there is a risk of hyperkalemia, then you will go for low potassium diet. But otherwise, if the patient does not have CKD, then a low salt diet and a high potassium intake is what is advised for patients to maintain the blood pressure. Again, please make a note of this. It is believed that increase in sodium, increase in potassium in the diet helps in natriuresis through the distal convoluted tubule. Please make a note of this. Increase potassium in the diet. How does it work? It is believed that it does many things, but out of that, the main mechanism is believed to be increased dietary potassium, improves natriuresis, improves the loss of sodium from the DCT and CD, distal convoluted tubule and collecting duct. It improves the exchange of sodium and potassium. So more sodium in the diet helps in excretion of sodium. So it works best when combined with a low salt diet. So a low salt diet with high potassium diet helps. There are various fruits which have high potassium. Two of them which are most commonly advised are bananas and coconut water. So two most commons are banana and coconut water. Apricot, what is that? Avocado. All of that also have high potassium. But I mean, there's a big list you can see on internet. But two ones that we practically advise almost all our patients is either have coconut water or have bananas. Oranges also, seasonal fruit, but oranges also Again, all those citrus ones tend to have high potassium, right? So you can advise any of these foods, and that can help the patient to control blood pressure. So dietary advice, very important set of advice. Third advice is physical activity. Please make a note of this. After diet comes physical activity. Third advice is patient should be advised physical activity, physical exercise or physical activity. And here, what kind of activity should I ask the patient? So if I tell the patient, bhai, tumhara blood pressure zyada hai, you need to be active, and tomorrow the patient hits the gym, is it a good idea? Tomorrow I'll go and pick up all the dumbbells and everything. May be a good idea, may not be a good idea. Please make a note of this. When you advise exercise, preferably advise aerobic exercises. Please mark this as important. When you advise exercise, preferably advise aerobic exercises. Cycling, swimming, walking, one of these. Cycling, swimming, walking, one of these is considered a good initial exercise. Cycling, swimming, walking, considered a good initial exercise. How much should be the duration of the exercise? I'm sure most of you already know this answer. So how much should be the duration of exercise, cycling, walking, swimming? Now, there are two schools of thoughts here. I'm going to give you both of them. The first, which I'm sure most of you know, 30 minutes of exercise. So 30 minutes of brisk walking for at least 5 days in a week. So first way that you can advise exercise is 30 minutes of exercise for at least 5 days in a week. So something like brisk walking or swimming could be done for 30 minutes in a day for 5 days in a week. There is another way in which you can advise the patient to do exercise, and that is 45 to 60 minutes of exercise 3 days a week. That is also acceptable. So 45 to 60 minutes of exercise 3 days in a week. Now, again, this advice will change from patient to patient. You have to understand the patient's lifestyle. So it's possible that the patient is having a very tough lifestyle, very busy lifestyle, and he or she says, well, I can't find time every day to go for a walk. I can't just do that. But I can find maybe 2 days in a week or 3 days in a week. Encourage the patient to increase the duration, right? Both options are fine. Start with aerobic exercises, 30 minutes for 5 days or 45 to 60 minutes for 3 days in a week, right? That is how we balance it. Both of them have been tested in trials and we find that the results are good. Second, first was aerobic exercise. Second is endurance training. So something like sit-ups, push-ups, all of them are called endurance training. Endurance training are strength building exercises. So please make a note of this. Endurance training or strength building exercises. Even they have shown to improve blood pressure over a period of time. Endurance training or strength building exercises have also shown to improve blood pressure. So it isn't that only aerobic exercise. So you can't tell the patient to walking karo, everything else is harmful. Not really. They can do everything if they can tolerate it. So of course they shouldn't do things in a way that they're going to injure themselves. Remember, this could be someone who is middle-aged or maybe an elderly person. So ask them to start slow and gradually build up the exercises, right? So first thing is diet, second thing is exercise. Third thing is addictions. Stop smoking. Please make a note of this. Non-pharmacologic therapy, quit smoking. And as far as possible, reduce alcohol. So please make a note of this. Two important advices here. Quit smoking. So quit smoking and moderation of alcohol. Reduce alcohol as much as possible. So quit smoking and reduce alcohol. With alcohol, when we come to the liver disease, you will come to know this. There is a problem with alcohol that alcohol cutoffs for Americans and the Westerners and Indians do not really match up. But nevertheless, we can say at least reduce alcohol. And finally, very important is weight loss. Weight loss, right? How much should the patient have weight loss? Remember, there is no data here that patient should have 1 kg weight loss or 2 kg weight loss. There is no targets really which have yet been defined in context of blood pressure. But we know that reduction in weight improves blood pressure. How much does it correlate? If I reduce, so if the patient says, okay, I'll reduce 2 kg body weight, how much will my blood pressure improve? Will my drug stop? Answer is, I don't know. We don't know. It might stop, it might not stop. We really don't know. So please make a note of this. Reduction in body weight improves the blood pressure. Reduction in body weight improves the blood pressure, but does not linearly correlate, does not directly correlate. I cannot say 2 kg hair loss means 2 millimeter fall there. We don't really know how much is that correlation. We don't have that evidence, that data yet. So I repeat, management of hypertension, first is the non-pharmacologic therapy. Then of course is the part where is our forte very often is pharmacologic therapy. Second is pharmacologic therapy. And when we are giving pharmacologic therapy, there are going to be some principles to follow. Please make a note of this. What are the principles in pharmacologic therapy? The first very important principle in pharmacologic therapy is start with a low dose. Start with a low dose. Right? Please mark this as important. As clinicians tomorrow, your first job is do no harm. Do not push heavy doses right at the beginning, because there is a risk that the patient might land up in hypotension. So please make a note of this. Always, always, always start with low dose and gradually increase it on a weekly basis. Every week or every once in 2 weeks, whatever way that you can monitor the patient, you increase the doses in weekly basis. So let me give you an example. If a patient comes to me with a systolic blood pressure of 160, I don't really want to give him a drug today and say, okay, 2 days later it should come below 140. If he's at 160 today, remember that 160 is going to harm him after 10-15 years. The risk of coronary artery disease, stroke is after 10-15 years. But if I get him to 90 systolic right now by giving a heavy dose, the risk is right now, right? So I don't want to take the risk of overdosing the patient. Start with a low dose. If he's at 160, next week if he comes back with 150, I'm still happy, it's working. I might want to increase the dose. If he comes with 130, I'm better. But even if it does not come with 130, it is okay. Do not push heavy doses right in the beginning. Start with low dose. Second principle, start with a single drug. Monotherapy at all times. Please mark this as important. Always start with monotherapy. So start with monotherapy. Increase the dose to the maximum tolerated dose and then add a drug. So I repeat, start with monotherapy, increase the dose to the maximum tolerated dose, and then add a new drug. Right? Third, always, always, always watch out for adverse drug reactions. Monitor the patient. That's the other way of saying this, that whenever you start a patient on any of the antihypertensive drugs, always monitor the patient for its adverse effects. Right? Now, when you start these drugs, please make a note of this. The first choice of almost all the guidelines today are ACE inhibitors or ARBs. Please mark this as important. For hypertension, the first choice of almost all the guidelines today is ACE inhibitors or ARBs. And remember, at all points I've been saying ACE inhibitors or ARBs because really speaking, you have asked me this question earlier also, which is better? There isn't enough data or enough evidence to say that one is better than another. Of whatever we have understood till now, both are equal. We use only one of them, either use ACE inhibitors or ARB, but both as of today stand equal. Right? Now, these are the first choice in almost all conditions, but they're especially important in certain cases. Please make a note of this. These are first choice in almost all conditions, but they're especially important if the patient has a background history of, you already know it, diabetes mellitus. If the patient already is a known case of diabetic nephropathy. So diabetes mellitus plus hypertension, I'll use it. Patient of hypertension with diabetic nephropathy, I will use it. Patient has heart failure. He's a known case of heart failure. Or if the patient is a known case of coronary artery disease. In all of these conditions, I'm going to consider ACE inhibitors and ARBs. ACE inhibitors and ARBs are also considered in patients who are obese or, in other words, have metabolic syndrome. Remember, these are the very patients who are at high risk of developing everything that you've written in this line. Obese and metabolic syndrome patients are at high risk of developing diabetes, of heart failure, of coronary artery disease. So if a patient is obese or has metabolic syndrome with hypertension, even without heart failure and CAD, I will still consider ACE inhibitors and ARBs. Right? When I use this drug, I'm going to watch out for 3 very specific adverse drug reactions. First is I'm going to look at serum electrolytes. I'm going to look at potassium. There is a risk of hyperkalemia. Always, 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 when you're using ACE inhibitors ARB, watch out for the risk of hyperkalemia. I'm also going to look at serum creatinine. Please remember, we have said that these are drugs which can precipitate acute kidney injury. So keep a watch on that. Third, not very common, but important, angioedema and persistent cough. You already know this. Both of them are adverse effects, not of both, but only of ACE inhibitors. When you start ACE inhibitors, ARBs, watch out for these adverse effects. Apart from ACE inhibitors, ARBs, the other options that you have are calcium channel blockers, the dihydropyridine ones, the dihydropyridine that is amlodipine, or thiazide diuretics, where the commonest one is hydrochlorothiazide. Right? We can use any one of them or we can use all 3 of them. So please make a note of this. The preferred combination therapy. So where we have written add-on, please make a note of this. The preferred combination therapy for today is ACE inhibitor or ARB, whichever one that you're using, plus calcium channel blocker, plus thiazide diuretic. This is today considered the preferred modality. Right? Of course, if you can manage it with one of them, you use one of them, but if you can't manage with one of them, you might want to add all of this. The fourth option are the beta blockers. The fourth options are beta blockers. Unlike what I think has been taught in pharmacology, please remember beta blockers today are not considered the first choice of antihypertensive therapy. Please mark this as important. Beta blockers today are not considered the first line of antihypertensive therapy by any of the guidelines. None of the guidelines now says that beta blockers should be number 1, right? For routine control of hypertension. Beta blockers are preferred specifically when the patient has a past history of myocardial infarction. Patients having past history of myocardial infarction, these are the ones where we prefer beta blockers. Beta blockers are also preferred if the patient has heart failure. Right? In these 2 conditions, we do prefer beta blockers. And of the beta blocker, the most commonly used is metoprolol. And nowadays also carvedilol. Right? So I repeat, management of hypertension, the first and the most important drug are ACE inhibitors, ARBs. They remain the first line of agent. We start with a single dose. We increase the dose gradually. If the patient does not improve with that, then you can add a calcium channel blocker and or you can add a thiazide diuretic. Apart from this, there is another drug that is beta blocker. Beta blocker per se is not the first choice unless you have those other risk factors. Now, one thing over here, please make a note of this. Combination of ACE inhibitors with beta blockers does not give good blood pressure relief. Please make a note of this. For hypertension, we avoid a combination of ACE inhibitors with beta blockers. They don't really add much to each other for antihypertensive action. But you will still find these being used very often in post-MI patients. Some of the batches I have finished cardiology or at least spoken about myocardial infarction. You might remember in MI, I have given you both of these drugs as together. In heart failure also, both of these drugs are used together. But for hypertension only, if patient has no MI, no hypertension, no heart failure, then I don't want to combine ACE inhibitors with sympathetic blockers or beta blockers, right? You can either combine ACE inhibitor, calcium channel blocker, thiazide, or if for some reason there is a contraindication to ACE inhibitor, you don't want to use it, you can't use it, then you might want to combine beta blockers with maybe calcium channel blockers and thiazide, or beta blockers and thiazide. That works much better than beta blockers with ACE inhibitors. Remember, I'm saying this in context of hypertension. There is no contraindication to using them together. You can use them together, but just that they won't help hypertension per se. They will help heart failure. They will help in MI, right? We'll talk about those mechanisms over there. One last part over here. What would happen if the patient has resistant hypertension? Please make a note of this. What is resistant hypertension? What should I do if the patient has resistant hypertension? Now, resistant hypertension means any patient who has received 3 or more antihypertensive agents. So you have given 3 or more antihypertensive agents, and yet the patient's blood pressure has not come under control. So you have given 3 or more antihypertensive agents, and yet you have not achieved the target. That is called resistant hypertension. And the most common cause of resistant hypertension is poor compliance. Please mark this as important, that you will have to ask for compliance. Is it really that the patient is taking the drug? You have written down that take all these drugs, but maybe the patient is not consuming them. So the most common cause of resistant hypertension is actually that the patient is not taking the drug. So in that case, you'll have to counsel the patient and convince him that he needs to take the drug. But the drug of choice over here, the drug that really helps in resistant cases now, is aldosterone antagonist, spironolactone. Please mark this as important. If someone is to ask you what is the indication of spironolactone, you can say spironolactone is the add-on drug in cases of resistant hypertension, right? There is one more drug that can be given. It's again an add-on drug, something which you know can bring down the blood pressure, but we have not used it till now. That is, you can have loop diuretics. They are not to be used in routine management of hypertension. They are only to be added to drugs in case of resistant patients having resistant hypertension, right? There are other drugs like prazosin. There are other drugs that we use like alpha methyl dopa and all of them. But really speaking, they are not in general use nowadays. What is mostly used is one out of these drugs. So I'm giving you data from the guidelines and from what is happening in real world. Of course, in pharma, you have read many more drugs, but truly speaking, we don't really use most of the drug in routine practice now, right? Okay, so it's been a long time that I've been talking. I'm sure there are questions which are here. I'm going to take up your questions now. Some of you had also given me a suggestion that we should open up the chat box here, or I should open up the chat box on YouTube. I really don't like that option because, again, most of you are new to the idea of having an online lecture. So in online lectures, what happens is a lot of people write down questions. You might have realized, at least in your own group, there are so many questions which are coming up. In real world scenario, most people don't ask questions. There are inhibitions, but here a lot of people ask questions. What will happen is if I get flooded with all those questions, it will be very difficult for me to go ahead. Right now, I have the liberty that I can kind of slide over some questions and say, okay, I'll answer it later on. That ability to take some questions and leave some helps us to be on track and maintain the time. If I start having all the questions on screen, I will also be tempted to answer all of them, and it will only add to chaos, right? So let's keep it this way. I think again, this is something I've been trying for the last 2 years. We have tried other options, and I feel this works the best because it gives me the ability to kind of remove some questions and take some questions which I feel everybody will benefit from, right? If resistant hypertension is due to poor compliance, shouldn't we try to improve the compliance of the patient first? Of course, that's what I said. So if you have identified that it is because of poor compliance, then counsel the patient. That's what I said. And if you do not find that helps, then you'll have to add another drug. So of course, you are going to try and maintain the compliance first and then add one out of aldosterone antagonist or diuretic. Can high potassium diet be advised to a patient on ACE inhibitors with monitoring for hyperkalemia? The answer is yes. 4.7 gram per day is the limit that we have set over there. So yes, up to that much limit, if someone takes potassium, that can be advised with ACE inhibitors, unless the patient has CKD. It has been shown in trials that ACE inhibitor combined with high potassium diet is safe if the patient does not have CKD under monitoring. So legally also you are correct to advise high potassium diet up to around roughly 4.7 gram per day, with even if the patient is taking ACE inhibitors. Can calcium channel blockers be used alone? Yes, they can be. So please make a note of this. Calcium channel blockers, ACE inhibitors, thiazide diuretics. All the first three that I told you could be used alone also. But all the guidelines say the first should be ACE inhibitors. That doesn't mean we can't use calcium channel blockers. In my own practice, very often I use ACE inhibitors, calcium channel blockers. Amlodipine is very often my first prescription. If the patient, especially is an elderly one, I'm not sure of the renal status yet. I don't know, I don't have his creatinine value. Very often I start with amlodipine first. So there is nothing wrong in giving only calcium channel blocker also. You can do that. How long do we wait to declare that the patient is having resistant hypertension? So that's a good question. Resistant hypertension has not been defined along time. We don't define it on the basis of time, but you should know that roughly when I started dose, I would increase the dose every 1 to 2 weeks. And very often, so if I take an example of ACE inhibitor, I will start with ramipril. The full dose is 10 milligram. I would start ramipril at something like 2.5 or 5 milligram. If the patient does not improve 2 weeks later, I might want to increase that dose to full dose. Another 2 weeks later, I might want to add one more drug. So roughly, resistant hypertension is something I will diagnose around 4 to 6 weeks later, right? At this speed, I will usually diagnose it at 4 to 6 weeks later. But it has not been defined on the basis of timing. It has been defined on the basis of number of drugs required to control hypertension. What advice is given to a patient suffering from an episode of hypertension causing headache, dizziness, nausea? Okay, I should have stressed this very clearly. Please make a note of this. Please make a note of this. Hypertension in close to 85% to 90% of cases is asymptomatic. We do not treat hypertension for hypertension. We treat hypertension for risk reduction of coronary artery disease, stroke, and other things, right? So please make a note of this. 85% to 90% cases of hypertension, patients are asymptomatic. When the patient has symptoms, those symptoms are seen when the diastolic blood pressure crosses 100 or the systolic blood pressure crosses 180 to 200. So please make a note of this. Symptoms of hypertension very often would start manifesting when the diastolic blood pressure crosses 100 and the systolic blood pressure crosses 180 to 200. And at such time, the symptoms of hypertension could be occipital headache. The symptoms of headache of hypertension in such patients would be occipital headache. Sometimes patients can have dizziness, as you have written. Patients can present with pedal edema and other features of heart failure like dyspnea. So patients can present with pedal edema and other features like dyspnea, which is a feature of heart failure, right? If the patient has such features, then very often we start with loop diuretics. Please make a note of this. If the patient has such features of heart failure, we very often would start with loop diuretics. In such a case, your other drugs can be, depending on how bad is the hypertension, calcium channel blockers, so loop diuretics, calcium channel blockers. Labetalol is a beta blocker. Labetalol. And in really severe cases, nitrates. You might want to consider nitrates, intravenous nitrates, nitroglycerin. right? Intravenous nitrates. That is going to maybe around be 10% of your cases, but what I'm describing here is those chronic cases who are not symptomatic. There, it's not symptoms that you're treating for, but treating otherwise. If the patient has symptoms, the symptoms are very often going to be of heart failure. So your drugs are going to be diuretics plus minus calcium channel blockers, plus minus beta blockers like labetalol, plus minus nitrates if required. What is the appropriate frequency of increment? I think I've already answered that. So I think I've answered both of these questions, that what is the frequency of increment of antihypertensive drugs? It is every 2 weeks. At what blood pressure should you consider the patient to be in hypertensive emergency? It is the presence of symptoms more than the blood pressure that matters. If the patient has features of heart failure, that is the patient who's considered an emergency. But on an average, the diastolic blood pressure is more than 100, the systolic is more than 180 to 200. That's when I will hospitalize the patient and give one of these drugs. One of you has asked me what is the indication of sacubitril. I really do not know if there is a separate indication for that. I don't know about it. I'll read up and I'll let you know. Is there any cutoff of how should we increase the dose of a drug from 20 to 40, 40 to 80? The only cutoff is monitor the blood pressure. There is no cutoff here. There is no strict rule that, okay, if the systolic is 180, you give 40, or if the systolic is 160, you give 20. There is no rule over here. It's more of a titration. We say we titrate these drugs and different patients will respond differently. That's why you start with the lowest dose and you keep on titrating it upwards, because two patients, exactly same blood pressure, will respond differently to the same drug, right? So that's the tricky part over here, that you have to titrate the dose. There is no fixed dose for these patients. Are there any ANP, BNP like drugs which are used? So there are ANP and BNP like drugs, but they are not used in management of hypertension. So yes, there are drugs, but they are not used. Is ACE2 the same as neprilysin? I will have to read that up. I'm not very sure. Okay. Won't ACE inhibitors and potassium sparing diuretics together cause hyperkalemia? The answer is yes, they can. So please make a note of this. The part where you have written that you are going to add aldosterone antagonist, that is spironolactone. Please make a note of this. Spironolactone, when you are adding, monitor potassium. I should have added it over there. So when you add spironolactone, please monitor potassium. So when you add spironolactone, please monitor potassium. One more question over here. What are the other causes of resistant hypertension? There is a straight answer over here. First topmost cause of resistant hypertension is poor compliance. Second cause of resistant hypertension is secondary hypertension, that it is not primary hypertension at all. The patient has something else sitting behind, like OSA, like CKD, like renal artery stenosis. Then it is, you'll have to look at the secondary causes of hypertension, right? So again, thank you for that question. That if it is not compliance, then what is the cause? Then the cause is look for secondary hypertension. It could still be possible that there is no secondary cause, but now is the time to start investigating more thoroughly for secondary hypertension. Yeah, so two of you have asked me the same question. This is an interesting one. Why is it always advised to quit smoking but just moderate alcohol? Why not quit alcohol? Thank you for the question. You have also answered it. You have asked me, is this a reason? Is there any reason, or is this trial based? I think it's trial based. Really, I don't think there is a reason that I can tell you why not quit alcohol. I mean, it's of course okay to quit alcohol. You can always advise the patient to do that. But the trials that have been done have shown that moderation of alcohol is what we have tested, and that works fine. So maybe they have not even tested that very rigorously. I'm not sure of that part. But yeah, it's trial-based recommendations that as of now say moderation of alcohol. I'm not sure here, is this culture? I'm not sure of that part, but I'll not go into parts which I'm not sure. I'll just leave it at that. But yes, quit smoking, we agree on. Quit alcohol, there isn't enough evidence to say so. Of course, unless you have alcoholic liver disease, but for rest of the things, no, it has not yet been said. But it's an interesting question. Thank you for that. In a patient who has pedal edema as a side effect of amlodipine. What is the next step? Again, a good question because it's a common adverse effect. So most of you must be knowing this. Amlodipine causes pedal edema. Actually, it doesn't cause pedal edema. It causes ankle edema, right? It causes, and specifically around ankle, you'll find edema. Well, it's considered to be a benign condition. So unless the patient says, I don't want to take the drug, there is no reason to do anything. So please make a note of this. Ankle edema because of amlodipine. The only thing required is counseling. You need to tell the patient this is not harmful to you. This will happen. And if you don't want this to happen, the only option is change the drug. But if the patient is okay with it and the patient very often says, okay, if it's not going to harm me, I have no problem, continue. It's very often a mild edema. So nothing specifically has to be done for patients having only ankle edema because of amlodipine. Of course, you have to remember there is a possibility that what you're seeing is not ankle edema because of amlodipine, but the patient has heart failure or CKD. So you have to be very sure before you attribute it to amlodipine that you have thoroughly taken the history, examined the patient, if required, investigated the patient for CKD or heart failure by doing an echo or creatinine, and then commented on that, right? So if you have a doubt, then don't say don't do anything. First you investigate. But if you're sure this is amlodipine causing edema, nothing actively has to be done for it. I have nothing to say about COVID. So one of you have asked me a question between COVID and ACE. I have nothing to say about it. It's too early to comment on it. Perhaps there is something there, but I have nothing to say there because it isn't clear yet. Okay, so yeah, this is a good question. I have said that diabetes mellitus is an association, but not a secondary cause of hypertension. Why? Oh, that is a very interesting question because I would want you to remember there is a difference between cause and association. You have read this in PSM. If you have not read this in PSM, either you're in third year or I don't know how you reach the final year. So I'm just kidding. But this is there in PSM, right? That there is something known as association, there is something known as causation. So if I have renal artery stenosis and I correct renal artery stenosis, the patient's blood pressure should improve. That is, renal artery stenosis causes hypertension. Correction of renal artery stenosis reduces hypertension. If I have diabetes and I have hypertension, will correcting sugars improve hypertension? Can I tell a patient of hypertension and diabetes, let's give you metformin for your diabetes, the sugar will come down, the blood pressure will also come down? No, that doesn't happen. So it doesn't fulfill the criteria of saying that every time that I correct diabetes, blood pressure also gets corrected. It doesn't happen, right? So there are these criteria. There is, I'm forgetting his name. What criteria? There are 7 parts of that criteria of what is association and what is causation. It's there in your PSM books, the community medicine books. So please go through that. Diabetes doesn't fit that bill. It comes very often with hypertension, so we call it the association. But correcting one does not correct the other, so we don't call it causation, right? So that's a good question, but yes, diabetes is an association, not a cause of secondary cause of hypertension. Okay, again, it's a good question. How do we interpret someone who has blood pressure which is systolic, maybe sometimes predominantly systolic, predominantly diastolic, or just one of them is elevated? Now, it's a really difficult question to answer because there is no one clear answer. So for example, in elderly, it is very likely that you might get isolated systolic hypertension. It's a commonly described phenomena that elderly patients have isolated systolic hypertension. It's also described like hypothyroid patients tend to have an isolated diastolic hypertension. There are some things that we know, but again, there isn't a very clear demarcation that every time I have a systolic hypertension, it means something. So I'm sorry, I don't have an exact answer to this question. What should I interpret when I have a only systolic or only diastolic? I can tell you this, all the guidelines today agree on this, that whether it is only systolic or only diastolic, you still need to treat and achieve your targets. Whatever has been the target defined by the guideline that you're following, you still have to achieve it. You will want to look at secondary causes, but most likely, remember 85% is primary, sorry, 95% is primary. Most likely you'll find nothing even if you have just systolic or just diastolic. Hypertensive emergencies and urgencies. I think a lot of you have asked that question. Maybe the next time we start the lecture, I'll just give a little on that. Really speaking, this is a concept which is very stressed to you upon in pharmacology. In medicine, I'm not so bothered about hypertensive emergencies and urgencies as a separate story because, well, they come to me with heart failure. I treat their heart failure, and this is a kind of a byproduct that gets treated. But I'll still go into it since almost 4 or 5 of you have asked me the same exact questions of what about hypertensive emergencies and urgencies. Seems like you're very interested in it. So I'll talk about it next time when we start. Maybe for a short while, I'll talk about emergencies and urgencies, and I'll take it there. But remember, in medicine, they don't come to us only hypertensive emergency and urgency. I'm more bothered about the end organ, heart failure, which is the association, right? I treat that part. Okay, so what I'm going to do is I'm going to ask you to pardon me now. There have been a lot of questions. I will perhaps answer them on your groups, and please use the discussion forums that you have so that everybody is able to see and benefit from your questions. Some of these questions are a lot of things that you have thought about and asked me. So let me also go back and think. Some of the questions I've been able to answer, rest of them I'll answer them on the group. And if there is a really good question, maybe I'll pick it up next time and answer it right at the beginning. Now, one thing before we close this, tomorrow there is no lecture, but tomorrow for short whiles I would be talking to you. I'll be putting up a link that maybe for half an hour I would like to discuss with you about what's going to be the future plan of action, what topics are we going to take, and how are we going to proceed. From Thursday onwards, your lectures. Right now, I'm talking to Mumbai Pune batch. I'm talking to you both as one block because you guys are at the same pace of the curriculum, and the rest of the centers which have just started, the rest of the places where you are just joined into these lectures, I'm talking to you as a separate block. These two will separate out from Thursday onwards. So tomorrow we don't have a lecture, but I'll still be talking to you tomorrow for a short while. I'll put up a link where you just need to come online and we can talk. We can see what happens next. I'll also be discussing tomorrow. I'm now right now addressing students from Mumbai and Pune. A lot of you have applied for the Wiki program, and for you, I'm going to give you the instructions tomorrow of how things are going to go ahead. So I'll be giving you a separate link. Please join in at that time. I'm going to demonstrate how things works over there. And from Thursday onwards, we are going to have lectures in pulmonary medicine. Those are going to happen for the online batch. And for the Mumbai Pune batch, the lectures would be in endocrinology. Those will happen separately, right? So there will be two set of lectures happening from Thursday onwards, right? So I would be very interested in listening to your feedbacks. As I've said already, I understand the concerns about technology. I would say rest your concerns, focus on your studies. That's what is of importance right now, right? Thank you so much. Take care of yourselves and stay safe. Jai Hind.